Hello, everyone, and welcome to this month's installment of Let's Talk, presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. My name is Anthony Knox, and I will be your host today. Today, we're going to be talking about it's in particular to one town, but it very much is a service and support that is greatly needed in the town of Sharon. And so we're joined today by Dena, part of the Sharon Health Initiative, who is going to talk us through, all of the different pieces related to this and be able to answer any questions that you guys may have about it. So, Dena, I'm going to bring up your slides and let you take it away.
Sounds good. Thank you, Anthony. So I'm Dena Wilkie. I'm the Community Healthcare Coordinator for the Sharon Health Initiative, and thank you for having me on, Anthony. We're going to talk about the initiative, how we got started, what we do, and where we hope to go in the future.
Perfect.
So our mission is to provide personal attention, assessment, advocacy, and referral within the healthcare system, especially for our elders who need assistance aging in place. And I'm going to break that down a little more in just a minute. But first, I'd like to tell you all a little bit about myself. My title in this role is Community Healthcare Coordinator. I am an occupational therapist by training. I have my master's in science from Columbia University. I've been an OT for just about 12 years. I have extensive home health experience. I moved to Vermont about 8 years ago and did many years of home health, and got really interested in aging in place and supporting our seniors in their homes. That sort of brought me to get my certified aging in place credentials and my executive certificate in home modification and, a few other steps. But What I think the OT, the occupational therapist lens, brings to this role is the holistic view. We are trained to look at the whole picture, person, place, environment. It's not about the person's disease. It's about the person and their goals. So that is really applicable to this role as a community healthcare coordinator. Additionally, OTs are trained with a strong psychosocial and mental health background. And actually, I have my bachelor's of science in psychology. So you cannot interact with the people without using your skills as a psychologist. And lastly, I did spend several years working at a Brown University teaching hospital in the intensive care unit, total joint center, general med surg. So I have a really good and strong medical background. I understand the diseases and their processes and, what might be going on with folks. So I learned about the Sharon Health Initiative when they put an ad in the newspaper looking for board members. And I reached out and became a board member for about 2 years before we had our RN move on. We looked for an RN for a while without any applications. And ultimately, the board supported me and nominated me for this role. And I think it's a fantastic fit, again, based on what I just mentioned with the holistic viewpoint, the mental health background, psychosocial focus, et cetera.
Yeah, absolutely. I mean, I'm not going to lie. It seems like your entire life has kind of been building to this role as far as, all of your experiences and your training and education and things like that. It seems like the board made the right decision putting you in this role.
It's cool you say that, Anthony, because when I did apply for the board position, the whole time I was thinking, man, this is such an OT role. I want it. And it just so happened that it evolved this way.
Yeah.
But absolutely, I think I've got a lot of strong life experience in varied settings across, many different types of people, and adding in the home element, it's where people are ready to make changes. It's where it's most important to make changes. So just to talk a little bit about how Sharon Health Initiative got started, the woman in the photo is Phyllis. She's a client of ours who gave permission to share her photo, and her dog Peanut. The initiative started about 2016 is when they incorporated. Prior to that, a group of volunteers saw a need for community-based services, and they really were pioneers in this. They went about organizing themselves to create the initiative. We initially had support from the Community Nurse Connection, who I know you've interviewed before, Kristen Barnum. They helped set us up with an initial grant and an electronic medical record. When we first started, we were employing a nurse, and then we had a social worker, another nurse, and finally, I've been in this role. It'll be 2 years this February. Wow. So the program has really kind of shifted, and I think each discipline that has been in this role has kind of brought different perspectives and broadened it in different ways. We are no longer part of the Community Nurse Connection. Unfortunately, when they hired me as an OT, the board of the Nurse Connection decided to cut ties. And what that meant for us is that we've had to create our own supports and our own sort of version of an electronic medical record. I will say the downside is that we have a lot of great data we could be contributing to their program, but unfortunately, they're deciding at this point to keep it really RN focused. So I hope someday we can contribute that data, because they're doing amazing work as well. We all have the same goals.
Yeah.
So currently, we rely on grants from the town. We get some funding from the town. We apply for a lot of grants, and then we do some fundraising. Although I'll speak to that a little bit later. You know, some barriers to accessing funds. Any questions there, Anthony?
No, I mean, I guess my only question. I mean, obviously, yes, we, a couple months ago we did the presentation about the Community Nurse Connection, and I obviously was aware that RNs are the primary individuals related to that. I was just kind of wondering from your experience or your connections and things like that. Are you aware of other towns that utilize an OT in a similar fashion as the Sharon Health Initiative does with this program?
No, yeah, that's a great question. I'm not, but honestly, as you mentioned, OT, this is an OT role through and through. Yep. And each profession brings their own skill. And I don't want to throw anyone under the bus here by any means. Kristen Barnum has been wonderfully supportive, but what I see is none of the disciplines that are licensed, an RN, an OT, a PT, et cetera, we can't do what you call skilled work unless we're under a doctor's order. So even though we have these lovely RNs in the home, they can't do the skilled work. So they can essentially do what I do, which is we can take vitals. We're not allowed to interpret. So just to kind of circle back, I think it would really be beneficial to put more OTs or medical social workers within this, because we have a lot more training in the psychosocial piece, the holistic viewpoint, the advocacy, and knowing the community resources and what's out there. And we need RNs where they can do skilled work, because there's a significant nationwide shortage, I think, as you know.
Yes, we do.
Yeah. So I try to advocate for OT in this role, again, for the reasons I mentioned: the holistic viewpoint, the strong medical background, the psych background, psychosocial background, that ability to zoom out and kind of encapsulate the whole picture, and then problem solve for all the things down the line.
Right. Yeah, no, that makes sense. And then the only other question I have, and you may touch on it in the rest of the slides coming up, but Sharon, Vermont obviously is a geographically very interesting town as far as medical care that could be provided. I mean, obviously Gifford Medical is not very far away. Dartmouth Hitchcock isn't very far away. Within your almost 2 years that you've been in this role, have you seen kind of a balance of patients going to both of those facilities, or are there other, other care that these individuals are receiving outside of the support that you're providing at home, from other, medical sites?
Yeah, yes, absolutely. And I will touch on that a little bit. And in fact, this slide does talk about the Gifford. So I find they're pretty split. Definitely folks are still seeing specialists at Dartmouth.
Mm-hmm.
To be completely honest, I've been helping a lot of my folks move their primary care to Gifford
Mm-hmm.
because we've just had much greater ability to get people in a timely fashion, phone calls returned. I have the memorandum of understanding with them, so they know me. I can work with their community health team. And it's closer. A lot of they'd rather just jet up to Randolph than go down to the big hospital. And so, yeah, they're being seen kind of by both,
Okay.
and some Alice Peck Day as well.
Oh, okay. Yep. That makes sense too.
Yep. And I have some folks from the VA.
Oh, nice. Okay. Yeah. I mean, and we all know, especially, us in this area, I mean, the VA hospital, is huge and is a great resource for all of our veterans, but it's also really the only VA hospital, in this area by, for miles upon miles, to get to any other VA hospital. So.
Right. Yeah. And I think the Sharon folks, they're, is a more rural town and their comfort level is just with the smaller organization. Yep. Yeah.
Perfect.
I just want to talk a little bit about how our format is, how we're set up. So I currently work on Wednesdays and Thursdays. It's a 10 to 15 hour a week position. And I do want to give a shout out to the Sharon Congregational Church. They've been really lovely and forward thinking. When their reverend left, they knew their search for a replacement would take a long time. And so they liked what we were doing, or I was doing with the home visits, and felt like that was something missing from their pastoral care. So they actually have given us some funding, particularly toward home visits in a non-secular, or in a secular way. There's no proselytizing happening. But that's been allowing me to increase my hours a little bit more, which has been great.
Awesome.
Yeah. We've recently started drop-in hours at the Baxter Memorial Library in an effort to kind of find those folks that aren't finding us and maybe make it a little more approachable and casual. So that's the second and fourth Wednesday of the month from 2 to 3 p.m. In fact, I'll be there today at 2. Yeah. And when I first took on this role, it was pretty overwhelming, to be honest, because we had to recreate our version of a electronic medical record and how we were going to organize ourselves, what data we were going to collect, and build our caseload, our community engagement. So I spent a lot of time doing that and trying to build the caseload and really connect with the community, especially the community nonprofits, so they knew we were out here and what kind of work we were doing. I was able to get a memorandum of understanding with the South Royalton Rescue Squad. And so they've created a form, and we have, which is essentially like a release that they carry on the truck with them. So they give it to any appropriate non-transfer calls they go out on. So let's say they get, Mr. Smith, second call the week for falls, but he's not going to the hospital. They're going to check out his home situation. They're going to see what's going on. And then they're going to, on the spot, get that clearance, that release to inform me so I can follow up with them. They've got our brochures and our business cards, and we've gotten some good referrals from them that way.
Excellent.
And it works twofold. I mean, I've had folks who I say, do you have any, can you drive by and check on that person? Or they're wonderful. I can't say enough good things about Becky Owens over at South Royalton Rescue. She's been instrumental in getting this up and running. And then same for Gifford, that it just having that memorandum really makes it simple for me to help with continuity of care, get the clients the access they need, follow up on appointments, med questions, etc.
Awesome.
And then again, just the community based, I started last year going to their old home days, having a booth, and just putting myself out there, letting people know who we are and what we're doing and what we offer. And the next slide will touch on this, but this is a free service to Sharon residents. We currently don't have strict guidelines on who I can work with and who I can't. We're open to renters. You don't have to be a homeowner. We tend to serve seniors for sure, but I am seeing more folks in their young 50s with some serious chronic medical conditions that could use support. So I have the youngest person I have is 49. And the oldest is 90, going to be 93.
Wow.
Yeah.
And what, I mean, roughly, what is your caseload size, with the town?
It's about 12. I swear I'll take 2 on and 2 will fall off. So it varies. There are, I'd say, about 10 folks that I check on weekly, whether that's in person or phone calls. And then there's, a 3 to 5, depending on what's going on, that I will call and check every other week, or they reach out to me every few months. We are able to keep it really flexible and meet the client where they're at. I have someone, maybe I don't hear from her for 4 months, and then she'll call up and say, hey, I need to get this booster shot. How can I get it? And, similar. So I like that aspect too, where they know they can come back when needed.
Nice.
Yeah. So some of my folks were already on when I started. I think I've probably got about 5 that have been on since 2016. Which is just another bonus. You really get to know these people and what their needs are. And I've developed some strong relationships with them.
And have you had, have you had individuals that have been there since, the day one that you walked in?
Yeah, they were there before me. They were there with the other nurses or social worker. And they're my kind of super seniors, people in their late 80s or early 90s. And again, I think the best part about this, it's so individualized. I really just assess, as you can see on the slide, we start with an assessment. What are their needs? What are their goals? That's really important. First and foremost, what are their goals? We take family input, of course, caregiver input. And then we look at what are their medical diagnoses? What stage or condition or management are they in with those? We look at meds for sure. That's a big piece of just you making sure that they have updated med lists, that they understand why they're taking them. If we see any concerns, we call up the primary care and just ask for a med reconciliation. And then we look at the home environment too. So big focus on fall risk reduction through home modifications and just some behavioral changes. And basically just trying to set the home up for them to be as independent and safe as possible.
Awesome. That's awesome.
Yeah, it's good. And so the services can really vary. I mean, we almost always perform advocacy, might be referrals to other nonprofits, fuel assistance programs, food shelves, Meals on Wheels, community health teams, different specialists. Like if, for example, you've got someone with a vague dementia diagnosis and, making sure they get to a neurologist. Or, visual issues, they follow up with a vision specialist, things like that. We've done family meetings. They can be really informal. I have some that we email every other week or so. Or I've had, harder in-person ones with a specific issue we're tackling. Long-term care planning and advanced directives, the home modifications and durable medical equipment recommendations. And that includes where to find them in the community for free.
Right.
Because finances are an issue for most of my folks. I'm able to take vital signs. Again, I don't interpret them, but if it's high, I'm going to call the primary care, suggest they call the primary care, or low, teaching them about their health, especially around congestive heart failure, diabetes management, importance of med compliance. folks who are in the hospital, I'll follow them in the hospital. I'll follow them weigh in on discharge planning, follow them to rehab if they go visit them, and try to help with home health if they come in on the other end. So good continuity of care there. And and I'm going to talk about the music project in a minute, and volunteers are also, we'll talk about a little bit later, but that is a huge piece of what we do and what we need to function is the volunteer piece.
Yeah. And so, and I mean, obviously, so you mentioned that this is only a couple days a week, at least for now, that you're providing supports to individuals. And, is there, I guess my question is, so I assume there's probably people that and I know you've already mentioned that there's some people that, maybe you talk to every 3 or 4 months just because, it's just a maintenance check-in or whatever the case may be. And then, but I'm also assuming that there are probably people that, on, every Wednesday you see this individual, or every Thursday you see this individual. And so there's that, I assume that there's that consistency for those individuals that need it.
You got it. So for example, I'll call him Mike. Mike is in his 90s. He's very isolated. He denies depression, but he presents as depressed. And he also has sort of a cognitive impairment that impacts his understanding of heart failure. He's very anti-doctor. So I started working with his doctor. I take his vitals, I write them down. And if I start to see weight gains or, things happening that aren't normal, I shoot her an email and she helps, we kind of problem solve together, or I'll facilitate a telehealth appointment with him and the doctor. So he's one that's kind of more medically compromised that I do follow weekly. Mm-hmm. And it's been good. We've been able to get very timely med adjustments on his diuretics with the help of the doctor, and, with me going in and taking his weights and his vitals weekly.
Awesome.
Yeah. And then there are other folks they're isolated and lonely. And I'll talk about isolation in the next couple slides. But that is a really important component of what we do too, is companionship and social engagement.
Perfect.
Just a little bit more on services. We look at energy efficiency. We're currently working with the window dressers program out of the Upper Valley. They provide low cost or free custom built window inserts that make the window like a double pane. We've worked with Cover down in White River Junction. I'm always helping my seniors with their annual or biannual reapplications for fuel assistance and food stamps, things like that. We started looking at, who's got a smoke alarm? Do they have a carbon monoxide detector? Do they have fire extinguishers? I'd love to find a grant for that because, again, a lot of my folks are surprised at the cost of like a carbon monoxide smoke detector combo is about $30 or so. So at one point, the Sharon Fire Department did pitch in and buy some, but that is a piece I'd love to keep kind of building on, is like basic environmental safety. Do you have an exit plan in a fire? Do you have a fire extinguisher? Do you have a fire alarm? And then again, increasing access to tech, helping them get involved with nationwide connectivity programs. That's for the landline, the cell phone. Not the cell phone, internet. And there's another similar program for life alerts. Another thing I've taken on that, again, is just meeting a specific client need is food shelf drop-offs. I'm lucky enough to be, my office is in the Sharon Food Shelf building. And so I have a good relationship with those folks. And, I clear it with them first. But I have one client that every couple of weeks I call her, we walk through the food shelf, I shop for her and go drop it off. So, that's another piece I'd love to hand over to a volunteer, but for now it's working for this client.
Right. Awesome.
I'd like to credit Carol Langstaff with this music project, and really I should credit her the initiative too. She is a driving force behind getting more towns to set up these town nurse programs. So we got a Council on Aging, Central Vermont Council on Aging grant for music. Essentially, we know that music lights up different parts of your brain. It can help with depression, isolation, cognition, especially music that is from their past, their youth. So with this grant, we were able to buy CD players. And, I kind of took my OT skills to really assess the players. How friendly are they to use? How big are the buttons? How do I modify the player? Which I ended up doing with bump dots or neon tape so that it was like very simple to use. Got headphones, although a lot of my folks won't use them, but headphones are supposed to deliver the music much better. And, you feel the effects better with the headphones. And then I interviewed them for their musical preferences from their youth, talked to them about the role music plays in their health, their mental health, and their cognition. And then we hand them out, and it's been awesome. I think we've handed out 9 players, and people use them to different levels. I have my guy, Mike, I mentioned earlier, and that's a pretend name. He uses his in the kitchen every time he's in the kitchen. And I've been able to go back and make him more personalized CDs. So that's a pretty cool program we offer. And I know Carol was trying to also get it into the local library as well.
Oh, okay.
To lend. Yeah.
Very cool. And so, I mean, obviously, there's so many, studies out there about how, how music can really help with cognition and memory and all these different pieces and things like that. And so, for the, 9 or so individuals that you've, given these, CD players and made CDs for them and things like that. I mean, have you noticed, just better, just improvement around like cognition and things like that for them?
I have to be honest, I haven't seen that aspect of it. I don't know that, I feel like if they had a caregiver to actually implement it like a therapy daily, maybe. But primarily people are choosing how they're using it. I have seen it really impact loneliness. I mean,
Okay.
People who wouldn't have listened to music in a long time and who are getting joy and happiness from it, singing along, tapping their feet. I love walking in. The guy I mentioned earlier, he's so hard of hearing. So when I walk in, Patsy Cline will be just blaring. So it's been, I think, more like a fun addition to their day-to-day, kind of break up the monotony, and the TV's not on. It's something different. It brings back memories. They get to singing, and, I think it's more addressing some mental health things than cognition per se. Yeah.
Nice. Excellent.
Yeah. We're pretty proud of that program. Shout out again to Carol Langstaff. So nationwide, again, they're starting to focus on isolation as one of the top risk factors for health outcomes. And, it contributes to cognitive decline, poor health outcomes, decreased compliance to medical visits and appointments. So we wanted to see what we could do to improve that. And, part of it is just my visits, or matching them with a volunteer. Volunteers are difficult to get. And so we brought on this companionship program, started it in June, and essentially we're just really clear with the volunteers that you don't need to clean, you don't need to drive them anywhere, you don't need to cook. You're going to just call them or do a visit, and it's up to you which you guys want to work out. And that's gone well for like 2 of my clients. Again, volunteers, having a volunteer to commit is the biggest barrier. So yeah, that's just a piece of what we're doing to battle isolation. The other piece is just being involved in community-wide conversations about the setup of town, the infrastructure, transportation, and, how are we identifying these isolated neighbors? Who's out, who knows, Mr. Smith up on the hill, how can we engage him, how can we support him? So really trying to get back to sort of a town-wide support, neighbors helping neighbors type model.
And so you've talked about, the need for volunteers and the great impact that volunteers can have on the organization in particular. Do you guys currently have any volunteers, or is it really just you that's kind of doing all of this?
We have a couple wonderful volunteers, and what has happened sort of organically is that they get paired for a specific purpose and they hit it off and they kind of run with it and make it work. So for example, this really lovely volunteer, again, I'll call her Pat. She signed up to help with groceries once a month for someone to go and do her shopping once a month. And it has turned fully into this great friendship. She helped the woman get a new washing machine, looks out for her, will pick up her meds, just checks in on her, just another person to support her. So I think I've got about 5 consistent volunteers who are dedicated to their person. It is harder to get like one-offs, people who just need one help with one thing, or seasonal help. I do talk about that a little bit later, but a volunteer coordinator position could be my entire role. Right. Most nonprofits have a volunteer coordinator. So I'm always wishing I had more time to put towards like really actively recruiting volunteers and really sweetening the deal for them. And, I just don't, but that is something we're hoping to build towards. More time for me to build it. Or I have been courting one of our longtime volunteers and former board members to see if I can get anyone to take it on as a volunteer coordinator role.
Nice.
And I will say I am a member of the Upper Valley volunteer coordinators, and essentially post-COVID, all these nonprofits in the Upper Valley just decided we've got to join forces and share resources here and see how we can support one another in these roles, because it is estimated volunteerism is down by 50% since COVID.
Yeah.
And we're seeing that it directly impacts our ability to provide quality care and to meet our mission and our clients' goals.
Right. 100%.
Mm-hmm. Yeah. The other thing I brought, which is another kind of very OT perspective. OTs love to focus on leisure pursuits, we call them. What are you doing to keep busy? What are you doing to be engaged? So we used part of our Mascoma grant to bring in some fun things that I was hoping could kind of meet the needs of many different seniors with different abilities. We started with some low vision coloring books. So, bigger pictures. I gave them the coloring books, colored pencils, sharpener. And people have taken that on. One lady colored so much she thinks she hurt her shoulder. So I had her rein it in. But it was cool. I was pleasantly surprised the way they took to it. And, maybe they take it out while they're watching TV or after dinner. So that's been kind of fun. I did buy some I don't know if they're called seated pedal bikes, but they're the ones you set on the floor and it's just the pedals.
Yep.
Those, I think if we'd had more money to buy better ones, it would have been, that's what I would have done. These are a little bit, they're hard for the seniors to get their feet in and do the strapping. So, eventually I'd love to do something else along those lines where it's like a loner sort of very safe exercise they can do, to keep busy.
Nice.
Puzzles. In fact, I'm hoping this winter to do more of like a puzzle exchange, and kind of maybe bring on, might be another route for volunteers to be interested, come puzzle with a senior type thing. We were having what we were calling tea parties monthly, and those were really informal. We would provide tea and a little snack and people would come, and it started to get a little bit of the same folks. So we brought in like a theme. We did some like reminiscent stuff, some Sharon history, had the seniors bring in photos from, any photos they had of Sharon from back in the day, so to speak. And that was going pretty well, but again, sort of the same participants. So in an effort to draw more of the community in and make it more community oriented, we've sort of switched to these lunch and learns. And if anyone out there has any cute names for it, let me know, because we're not providing lunch. We don't have the budget for that, unfortunately. We are providing tea and, some sort of snack. And I just did a themed lecture last week on fall reduction, and had the attendees take like a self assessment of their fall risk, gave them some good handouts, went through like low tech modifications they can make that are accessible to most people that can really improve safety in the home. And so that went well, and we're going to just keep branching that out. I believe, though we're still confirming, our next one will be about smoking cessation. And then in the winter, we're hoping for a back pain and body mechanic one. So stay tuned for those.
Very cool. Very cool.
So again, just seeing what's reasonable for most of these folks are isolated to home. What can we do to just brighten their day a little bit, give them another option of things to do?
Awesome.
Again, I mentioned community a few times, but without the support of folks in Sharon, we can't keep going. So there's a lot of great folks here that are interested in improving their town and starting different initiatives and supporting what we've got going on. So community it's a big focus for us. There's a great program online. It's free. You can become a Narcan first responder. And so I recently took that, in an effort to decrease stigma and be prepared. A lot of seniors were prescribed opioids before kind of the restrictions came in. So I actually have a lot of older folks on opioids. And as you get older, your body's ability to process changes, and they're actually at risk of overdose. So I think breaking down the stigma of what it looks like to be using opioids and be at risk for an overdose is important. I'm collaborating with local focus groups on mental health and substance abuse. We kind of had a big wake-up call would have been December. We had those 2 ice storms sort of back to back.
Yeah.
Sharon got hit hard. We lost telephone, internet, you name it, obviously electricity. And we kind of realized, oh my gosh, we don't know who these vulnerable people are. So I was able to kind of get on with the local rescue squad and the emergency management folks in the fire department to start talking about what can we do better next time? How can we check on these people if there's no way to check on them besides driving over? How can we identify them? And so I was able to get several of my folks who were highest risk, nobody to check on them, isolated. They're just on a list now. And if something happens weather-wise or otherwise an emergency, they're just rescue squad knows to call them. And if they can't get them, they go out and check on them in person.
Nice.
Yeah. So we're just kind of having conversations around, how do people know what to do in an emergency? Are people prepared for an emergency? And I think it's an important component of what we're doing. Yeah. And then I sort of mentioned, great partnership with the Sharon Food Shelf. Mary and Bob Stoddard helped to run it, and Kit Hood. I should name more people, but a lot of great people doing really awesome volunteerism. And they've been very open and receptive to sort of allowing me to, help our seniors by bringing them food and getting food off hours and things like that.
That's awesome. Yeah. I mean, it sounds like to me that, where potentially you guys are lacking in, more volunteers. I mean, again, as you said, you have very dedicated volunteers for the ones that you do have, but it seems like the town of Sharon itself, there is a lot of people organizations, businesses, things like that are willing to work together for the greater good of Sharon that, is all encompassing as it relates to, a health initiative.
Yeah, I think so. And I think that, there's a lot of excitement about how we could grow and what's sort of missing from our role. And again, I think it was Two Rivers Ottaquiche just facilitated, and I'm sorry if I got that wrong. I think that's who it was, just facilitated these town-wide sort of focus groups that let the town come in and identify their primary concerns. And what came out of it was a mental health and substance abuse focus group. And we're sort of wondering how we can collaborate and build off of what we're already doing.
Right. Yeah. No, that's awesome.
Yeah. Yeah. I will say the rescue squad, I mean, everybody has been receptive to what I have to say around emergency problem solving and making sure people are taken care of.
Yeah. And I know, we're the VNH, we're in the process of doing some community presentations at the library. And I know that, the librarian there and the just the library as a whole, really wants to, support the community as much as possible. So again, it's another example of Sharon really coming together for the residents of Sharon. Absolutely.
And yeah, Shayna at the library, she's awesome. I think too, she was fielding a lot of sort of social issues for people coming in. Maybe they're transient or, housing insecure. And she was taking a lot of that on. And that's kind of how we got to speaking is, how can I help you? What can I do?
Right.
And she's very receptive to the drop-in hours. And she's doing a lot of great work as well.
Yeah.
Definitely outside of the scope of librarian, but
yeah, right.
It's what happens. It's what happens.
Yeah. No, that's awesome.
Yeah. I did want to put up barriers because we're not a very small nonprofit. I am the only employee. Funding is obviously a barrier. Directly impacts our ability to expand my hours or hire additional people, like especially a volunteer coordinator. And, sometimes we have clients who just need help with like a phone bill or those smoke alarms or a special shoe. And, there are little pots of money all over the place that I'm always learning about. But we would love to have our own little pot of money to be able to say, okay, let's help you out with X, Y, or Z. Talked a lot about the volunteers being a pretty big barrier. So if you're out there and you want to volunteer, we can almost always find a fit for you. I think long and hard about who the volunteer would be appropriate with, what are they looking for, who's a good match. And maybe the volunteerism is, with me in the office and admin stuff or volunteer coordinator. It doesn't have to be that one-on-one in the home if people aren't comfortable with that.
Right.
Data collection. I did mention in the beginning that we sort of lost the ability to collect this data. And, the town nurse model or community healthcare coordinator model is really gaining traction. And, from conferences I've been to and conversations that I've been in part of, we as a system are really moving back toward community care. And these town nurse models are really, we're on the ground. We know what's going on. We have the pulse of the town. I think every town needs to have one of these. In fact, I live in Royalton and I'm always getting people saying, hey, what do you have for people in Royalton? And nothing yet. Right. And again, Carol Langstaff, she has been instrumental and she's left our board, but she continues to advocate and try to get more towns to take this on. And in fact, she's trying to get to the state level to kind of mandate this as part of town. I can't think of the word, but mandate this is like something towns do.
Yeah.
And with the lack of data collection, I just, I feel like if we were all contributing our data, we could show our progress much better and funding would increase. So that's been a barrier, I think, is that it's just us standing alone with our little data set. And, it does impact our ability to get grants and funding.
Yeah.
And lastly, board members. We're actively recruiting board members. We've had a couple people leave And again, like, we count on the board for fundraising and for policy management and support of my role. And so my folks are getting stretched thin, and anybody that's interested, it's, let's see, first Mondays of the month, from 6:00 to about 7. So it's at minimum an hour a month commitment, ideally a little bit more if you're willing to take on, some subcommittee type work. And especially we're pretty limited on like medical folks right now. So I think that would also be really helpful, is to have someone on the board who could, also support me in my role with their medical background.
So one of the things that you brought up, and I want to echo, is around the fact that all towns in Vermont, New Hampshire, wherever, really should have resources like the Sharon Health Initiative or Community Nurse Connection or whatever, because of the fact that there are so many individuals that, going to a hospital, going to, a ton of doctor's appointments is not what they need, not the support that they need.
Mm-hmm.
And, within, visiting nurse in hospice, or Beata, or, the plethora of agencies in New Hampshire that, provide home health services, you have to meet certain criteria in order to have people come into the home and things like that. But
Right.
with your organization and things like that, it's not, the guidelines aren't as rigid as it relates to when people can be in there and the supports that are being provided. Granted, everybody, has a medical background and knows what's happening, but again, it's not necessarily providing in-home medical treatment. It should hopefully be able to help them stay at home much longer and get the supports that they need to be able to thrive within their home. But these supports are just so valuable that it seems crazy to me that this isn't already something that should be in every single town, and that there's funding from the state that's really trying to support it and things like that.
Absolutely. I do wish I had a better way to capture. I mean, I've had 2 actively suicidal folks that I've been able to get to the emergency room. Again, I'm not an emergency-based service. It just happened that these were happening during my work hours, which made me think, what if it hadn't happened during my work hours? I mean, I had people with a plan. It was pretty scary. So we look at that. We look at, you mentioned home health coming in, and having worked in home health for a long time, that's quick and dirty. It's the nitty gritty, in and out, right? And so then these people are just kind of left. Most of them can't or have difficulty initiating and continuing with the exercise programs or the dietary requirements and, things like that, which they were doing right along with queuing from home health. But then home health goes out and what, So that's where we can come in too, is just really shore up what home health taught, and also then be the ones waving our little red flags if they're not doing well and they need to go back in to the hospital or see their primary care or whatever. So yeah, Anthony, I 100% agree. I'm very proud of this program. I'm really proud of the folks at Sharon. I think it's very progressive of them to have been supporting this since 2016.
Yeah.
And I think yearly, I think they're seeing the benefit. Again, I think with good data collection, people they like the stats, right? And they like the money talks.
Yep.
But I think about that all the time. Like if if so-and-so misses her doctor's appointment because she didn't have a volunteer to drive her, and surprise, she's in heart failure, and now she has a 2-week-long hospital stay. And, could we have prevented that cost by just being set up to support her to the appointment?
Yep.
And it's a million little things like that I think are bogging our system down.
Exactly. And again, I mean, the beauty of, Sharon Health Initiative in particular is that you are able to, get eyes onto the individual, kind of assess what's going on. And, if the hair on the back of your neck stands up and just something doesn't seem right, then, you have the ability to be able to call and get additional resources for that individual. And I mean, at that point, they may qualify for home health support. So that way they can still avoid having to go to an emergency room or things like that. But being able to, being able to be the boots on the ground and really see what's happening is such a valuable resource. That is so underutilized, and the reason is that either it's money, staffing, or a combination of both is really the challenges that becomes with this type of service.
Yeah, absolutely. I mean, I sort of joke about it, but I remember so many folks, I'd be doing home health with them and they couldn't shower or get clean. I'd be worried, but they'd have a doctor's appointment. They would figure out how to get clean and put on a good face for the doctor, right? But if you're in their home and you're looking in their fridge and you're looking at their filled pill box they haven't touched, and you're seeing the dog feces on the ground or whatever it might be. Yep. Exactly. It's on that knowledge is, no one else can get that except for the folks in the home.
100%.
Yeah. Yep. You brought something up I wanted to touch on, but I've lost it.
Well, next time.
Next time. Yeah, exactly. I just wanted to speak to the trust piece. That's the other really crucial, is because I have these ongoing relationships with them, I can move at a pace at which they don't reject my recommendations out of hand. I can gently bring it up. And then a month later, I can gently bring it up. And eventually we do get somewhere, but it takes time, a lot more time than the 3, 4, 5, 6 visits you get with a home health, and then they trust me when I say, this isn't good. Let's go to the ER or whatever. They know me and they know I'm not going to just send them if things aren't okay.
Perfect. Yep.
Yeah. So I think just real quick, ways to reach the Sharon Health Initiative. Emails probably best, just because it is a 2-day-a-week position. You're welcome to call. The work number is 802-230-8458. And our physical location's 55 Route 132 in Sharon. We're across from the Sharon Congregational Church, and we're the second house on the right before you hit 14. But best bet is email, because my hours are a little erratic. I could be out on a home visit or not. And again, second and fourth Wednesdays from 2 to 3 at the library are also drop-in hours if you have any questions or just want to stop by and say hello.
Yeah, and it's right around the corner from where your home office is. So
exactly.
Having now done one presentation at that library, it was very easy to find, because I just had to drive by your office, so it worked out very well. So. Yeah,
and I wanted to say thank you to you, Anthony. I think this is a really cool program. I think it really brings together all the people doing good work out there and amplifies what you guys do at VNH. So thank you.
Oh, no, thank you for coming on and talking about this, because this type of service is something that really needs to be in people's minds and thoughts to, increase this availability. Mm-hmm. Again, not only just for the Sharon Health Initiative. I mean, it seems to me that, if the opportunity arose for you to make this a 40-hour-a-week position, you'd jump right on it and be happy to provide those supports. But I also think that there are just so many towns that don't have this at all. They don't have, they don't even have somebody for an hour a week, to be able to touch base and things like that. And it's something that is just greatly needed, and especially in, rural Vermont and New Hampshire towns that there are nothing else. There is no public transportation to get to and from these different doctor's appointments and other, resources and things like that. It's just something. So I'm always excited to talk to people who are providing this just such a valuable resource, and especially with my background of working in developmental disability and mental health programs, and providing case management and providing service coordination and doing all these different things. This definitely strikes the nerve from my previous professional life. So
yeah, cool, totally. It's a great gig. It makes sense. Like, it just makes sense to do this, and towns do have health officers, but they're focused on like major, like if somebody's garbage all over their property or, things of that nature, not the individual.
Right.
So
exactly.
I also would love to see that come down where folks are really investing in their communities by taking care of their seniors or folks who are struggling, living with chronic illness, things like that.
Exactly. So, well, Dena, thank you so much for taking the time and chatting about this. And, and again, for anybody watching this live, if you have any last minute questions here before we jump off, and anybody who is streaming this either on our YouTube or Facebook page, again, just rewind the video back a little bit and you'll have all the contact information for Dena. But yeah, so again, Dena, thank you so much for being a part of this, and just keep up the amazing work that you're doing.
Appreciate that, and same at you.
All right, thank you, and thank you all for joining us this month, and we'll be back next month for another great presentation. So we'll see you then.
Bye.